Well, thank you very much. It's a pleasure to be here, and Rich, thanks for coming down. It's great to have you here. And Scott and Glenn, who put this conference together, it really is following along. I mean, Bobby referenced the primary care and public health IOM discussion of yesterday. I think it's also true about the Investing in a Healthy Future report on financing, that it clearly is tied in here also, and there are very relevant references in that. That report, of course, calls for us creating a health system in this country. We'll say that, and everyone will immediately say health care system a moment later, but a health system of the public health world and the patient care or clinical care world. And that is really what we're talking about here, is how do we align these systems? Both systems have a broken finance mechanism, and neither system delivers the value that it should to the American people. And yesterday, Rich, you weren't here, but many of the graphs from the IOM report went up there showing what an outlier the United States is. And much of it is due to the fact that we have separated the clinical medicine from population health and public health, which we need to bring together. But as Rich mentioned, this has been a long history of separating our two fields, and it's not going to be easy to bring them back together. We really do have to view this as a cross-cultural enterprise, if you will. The language is different. I'll give you an example when we talk about population health, which has never truly been defined. We were counting on the IOM report to define it. We heard early they were going to do that less. And it was a simple footnote in there referencing one of the potential dozen definitions out there. And in due respect to them, it's a very hard thing to do. We actually, JR, if you're here, we actually commissioned somebody from Hopkins to try to do a literature search to help us define population health, and we had to throw up our hands too. But population health, in some circles, means my population of patients. And population health may mean providing clinical preventative services to my population of patients. Now, in public health, we tend to define a population by jurisdictions, political jurisdictions. Very different definitions of populations. And of course, in a hospital world where you have service areas or market share, those overlap with but are not consistent with our political jurisdictions. So we don't define populations the same, and our efforts and definitions are not consistent. So there's a lot of work for us to do. The language is very different, and in many ways the worldview is different between the two organizations. Clearly, incentives, the rewards are broken and very different. I came from the clinical world where for a while I was involved in prepaid healthcare, which very much like public health. You had a fixed amount of dollars to care for a population. Went into fee-for-service where I was paid for what I killed. It was a piecemeal payment from Henry Ford, thank you, and a very different incentive. And I saw a change in our physicians who went from talking about diabetic control in our practice to who's going to put the new roof on and who's going to pave the parking lot in the fee-for-service system. So those two are very different worldviews. We also have somewhat of a potential issue that we have to be right up front about, and that in many cases health departments license and regulate the hospitals. And when you sit down with a hospital, are you sitting down with your regulator, or are you sitting down with a partner? And I tried in my health department in Vermont to draw a firewall there so that the hospital CEO could always call to say, listen, we have an infection, we're not sure where it's coming from, as opposed to him calling me to come in and sanction him. And so we tried to separate that, but you can imagine calling your regulator is not always a comfortable thing to do. The CON process is another thing that health departments do, and how does that impact the hospitals positively? So we shouldn't take for granted that this will be an easy process. I'll also say that in many of my interactions with the clinical sector, many people in the clinical sector just simply don't get what public health does. And so we have to do a lot better job. They don't think, why would I call the health department? And then others, and one of the common refrains at the National Quality Forum, National Priorities Partnership, is we don't know what public health does, and are you accountable for anything? And then I'll tell them the stories about going out and picking up the Sunday newspaper and being crucified in it every Sunday by the press. And there's a certain level of accountability that you have. So we need to work together, we need to do this. There are great opportunities here. Certainly, the community transformation grants which came into health agencies, not all, but many, presents an opportunity to sit down with the hospitals to say, join us as we look at this community, as we look at how to improve the health. And depending on where you live, in many parts of the country, the hospital is the major employer. They're part of the social fabric and of the community, so you want them at the table, both as the major employer, who employs more than anyone else, but also the economic engine in many cases of some of our smaller communities. How could you not do your community transformation grant and community health without your hospital there? And I, of course, would say to the hospitals, how can you not do it without your health department there also? But you know, the CTGs are only here for a certain period of time, and we don't know how long they'll be here, whether they'll be sustained over time, which creates the real opportunity with the hospital community assessment and community improvement plan process, which the IRS has clarified, to actually have if we build that relationship and we invite hospitals to table for CTGs, perhaps we will be at the table as they do their community health assessments and community plans, which will be longer lasting because the IRS changes a lot more slowly than our grants do. So it's a real opportunity to build those relationships and start looking forward. One other thing I'll say about the hospitals is if you look at their boards, they typically are the leaders in the communities. And so they're the people you want to have, you know, as part of this process, invested in it. So tremendous opportunity there. As Rich mentioned, you know, hospitals are, each is different, and how often do we hear, if you've seen one health, I won't even repeat it because I don't like that, but health departments are different, so we have to allow some organic nature to this in different communities, and I believe states. I really personally think that the community in which the hospital resides, and if you're a chain, each hospital has to do the community health assessment in the chain. It's not the chain for overall. So I think each of them should work with their local health department, but I also actually think with the state health department where they are licensed so that they have the data and the larger health department engaged. The challenge we have is how do you allow the organic flexibility to occur? At the same time, there's enough specificity to provide both guidance and to make sure that there is some consistency in how this is done and the American people are truly benefiting. And I think that's a challenge for us. And we know we fight those battles in public health where we go locals to the state to say you can't, you know, don't overprescribe, states, the feds don't overprescribe what you're doing. The same dynamic exists here. But there is really tremendous opportunity. The accountable care organizations, and I agree with Rich, there have been models like this for years with prepayment with a per member per month to hospital systems, particularly when the physician hospital organizations were around and probably still are around. So it's not a completely new concept. But one of the things that is there's an opportunity here is what if we actually, if these new accountable care organizations were not only measured on patient care, what's the hemoglobin A1C, but what if we have some population health measures so we could start looking at, well, what actually is the incidence and prevalence of diabetes in the community? What is the rate of obesity in the community that leads to the heart disease? And hospitals, by working in that area and putting in some community benefit to lower incidence and prevalence and improve some of the conditions, could reap the rewards from the both savings and rewards from CMS for good performance in improving the community health. I think it would be a tremendous opportunity for public health and the hospitals to come together. And importantly, it has to be done in such a way that by doing the right thing and creating a healthier community, hospital isn't financially penalized. And that's one of the tremendous issues we have right now with our healthcare system. If you actually go out, improve the health, decrease your visits to your ER, your ICU, your surgical suite, you pay dearly for it. And there's only so much you can ask people to do for plain goodness. So the same is true of public health. We need to have a business model that works here. So really, how do people do well by doing good is a real challenge for us. And as Rich said, our current financial system doesn't reward that. And if we had time, I can give you some excellent examples in, for example, preterm deliveries where in Oklahoma now, they've worked with the hospitals to put what they call a voluntary hard stop it. Hospitals will no longer schedule a non-medically indicated induction for a woman under 39 weeks. They've seen a 22% drop in their NICU, NICU admissions. Hospitals are paying dearly financially for doing the right thing, and they shouldn't. And we in public health need experienced NICUs, and we need patients to have access to NICUs for their babies when they need help. Now, none of us believe that should be driven by physicians doing non-medically indicated deliveries. And yet, we also can't hurt the system that we rely upon. The same would be true of emergency rooms. We need them there, not to take care of colds and sniffles, but we need them there when one of us has a car accident or a heart attack. So, great opportunity, but we need to make sure that we come into this really exploring each other's worldviews, each other's language, and exploring the incentives that we all live within, so that we don't just glibly say, oh, well, the right thing to do here is, without understanding what the impact is, both on our hospitals and all the people that work there. One other thing I'll mention, this notion of population health, we really don't have measures now for what population health is. I mean, so not only do we have a definition, but we don't have metrics. And in this country, Congress has sanctioned the National Quality Forum to adopt quality measures. And that's what goes into the JCO measures or CMS measures or the NCQA measures. Well, a call just went out for the first time to the large health community to say, give us some valid measures that we can use in public health to say, okay, here's a measure of quality in terms of achieving population health, and here a hospital, whether an ACO or if they're looking at their community benefit, could actually say, that's a measure we're going to reach for and go for. We don't have those yet, and it's a tremendous drain on all of us. Once we have those, of course, then we're going to need to make sure we have integrated IT systems, information systems to share data back and forth. That is a real challenge for all of us. So. It's an exciting time. Frankly, we have got to work together. We've got to rebuild the health system in this country. We don't have the luxury of having separate public health and health care systems, just as we don't have the luxury of having local, state, and federal public health not aligned and working together. So again, I want to thank you, Rich. It was an excellent talk and really learned a lot. Thank you.